Good morning. I'm Shikha Sundaram. I'm the Medical Director of the Pediatric Liver Transplant Program at Children's Hospital, Colorado. The very first liver transplant in the world was performed at the University of Colorado by the legendary Dr. Tom Starzl in 1963. The first successful pediatric liver transplant occurred thereafter in 1967, but pediatric liver transplant really took off in the mid-1980s with the advent of reduced segment, or using a part of a donated liver, and living donor liver transplant. The program at Children's Colorado started in 1990 and has evolved to encompass 7 pediatric transplant hepatologists, 3 transplant surgeons, and an extensive multidisciplinary team. In 2018, there were about 8,000 liver transplants performed across the United States. Approximately 600 occurred in children. There were an additional 13,000 people in need of liver transplant. And because of this dire shortage of organs, the transplant community takes a very careful approach to the evaluation of all potential liver transplant recipients. The very first step is to determine if a patient meets a medical indication for liver transplant. These include a primary liver disease that progresses to end-stage liver disease. Biliary atresia is the very most common. Autoimmune hepatitis and primary sclerosing cholangitis, alpha-1 antitrypsin deficiency, progressive familial intrahepatic cholestasis, or PFIC, Alagille syndrome, and on occasion, acute liver failure. Liver transplant may also be used as primary therapy for metabolic diseases, including urea cycle defects such as OTC, or ornithine transcarbamylase deficiency, propionic acidemia, and methylmalonic acidemia. There are systemic illnesses such as cystic fibrosis that can be treated with liver transplant as well. And finally, primary hepatic malignancies that include both hepatoblastoma and hepatocellular carcinoma. The next step in the process is a formal evaluation of the potential transplant candidate. Patients and their families have an extensive visit with members of the multidisciplinary transplant team. This includes the transplant hepatologist and surgeon, transplant nurse coordinator, as well as pediatric transplant experts in infectious disease, intensive care, anesthesia, social work, psychology, pharmacy, and nutrition. Each member strives to understand the patient's medical history, including opportunities to optimize their current care. They also take the chance to educate patients and their families about the transplant process from different perspectives so that they gain a solid foundation of what lies ahead. There are a few contraindications for liver transplant, some of which are relative and include a history of malignancy outside of the liver, significant cardiac disease or pulmonary disease, neurologic dysfunction, and non-compliance or non-adherence to medical regimens. Absolute contraindications to liver transplant include active malignancy outside of the liver, HIV infection, sepsis or untreated or uncontrolled infection, and irreversible brain injury. After a patient has been evaluated, they are presented to the entire multidisciplinary transplant team. Each member who has completed the evaluation shares their perspective, including the need for additional data that may be required to make an informed decision about the candidacy for transplant. If a patient is approved, and in the vast majority of cases they are, they can then be listed for liver transplant. They are listed on the UNOS list, or the United Network for Organ Sharing list, which is a national computerized organ distribution network. Patients are listed based on blood type, weight, and their PELD or MELD score. The PELD score, or Pediatric End-Stage Liver Disease Model, and MELD score, or Model for End-Stage Disease, are numeric scores designed to prioritize organ allocation based on the severity of illness that is generated by a mathematical model using laboratory tests. PELD is used for children who are less than 12 years of age and includes INR, albumin, bilirubin, and in those children less than 1 year of age, both their age and growth parameters. For children who are 12 and older, the MELD score is used. This includes sodium, creatinine, INR, and bilirubin. There are some complications that may increase a patient's individual mortality that are not captured by these scores. These include GI bleeding, hepatopulmonary syndrome, recurrent cholangitis and infections, and these issues can be appealed to a National Liver Review Board for extra points on the list. And after that comes the hardest part, waiting for the gift of life through a donated organ.